Welcome back to AGIC Science into Practice, where we take the latest infection prevention research and talk about how it actually works in the real world. I'm Nikki, joined as always by my brilliant and possibly overcaffeinated co-host, Jess.
Oh, I am definitely overcaffeinated. Hello, everyone. I actually think caffeine is part of my professional development plan, Nikki. Today, we are talking about MRSA, specifically a smart, targeted approach to keeping it out of the bloodstream by starting with the nose.
That's right. Yeah, we are unpacking the article Reduction of Hospital Onset MRSA Bacteremia with the Use of Twice Daily Alcohol-Based Nasal Antiseptic in Intensive Care Units. And the team behind this study faced a rise in MRSA, and they countered it with something refreshingly simple: a twice daily nasal antiseptic. Results: noticeable drop in MRSA infections, and a reminder that sometimes the fix really is just right under your nose.
They didn't just add a new product and hope for the best. They were working with nursing, infection prevention, and even their EMR team to monitor compliance. You know it's serious when you bring IT into infection prevention.
And joining us today are three leaders from Henry Ford West Bloomfield Hospital in Michigan who made this project happen.
Yes, so we have Sarah Prascius, MPH-CIC, is an infection prevention specialist at Henry Ford West Bloomfield Hospital. Sarah received her Bachelor of Science from Michigan State University in 2017. From 2017 to 2021, she worked clinically in many specialties, including emergency, pediatrics, internal medicine, pain management, and endocrinology. I don't think there's anywhere she hasn't been. After shifting her focus to epidemiology and public health, Sarah received her Master of Public Health from the University of Michigan in 2022. She began her career at Henry Ford Macomb Hospital in 2021 as a quality specialist, later transitioning into her role as an infection prevention specialist at Henry Ford West Bloomfield Hospital in 2022. She became board certified in infection control in 2024. And I just have to say, I love that overlap from the quality specialist to the infection preventionist. It's wonderful.
Yep. And also with us is Alex Wells. Alex is a manager of safety and reliability at Henry Ford West Bloomfield Hospital in Michigan. Her background is in public health and hospital epidemiology, having completed a Master of Public Health in Hospital and Molecular Epidemiology from the University of Michigan. Very cool. She began her career in infection prevention in 2019 and played a critical role in the implementation of the COVID-19 response at her hospital. Wow, you started IP in 19 and jumped into COVID. Alex's focus areas include prevention of device-associated infections, high-level disinfection and sterilization, and performance improvement. She has been certified in infection prevention and control since 2021. Congratulations. And holds additional certifications as a Certified Professional in Healthcare Quality, CPHQ, and Central Sterile Vendor Partner, a CCSVP. Alex also serves as a member of her local APIC chapter board.
And last, but certainly not least, Dr. Tricia Stein, MD, FIDSA, FACP, is the Medical Director in Infection Prevention and Antimicrobial Stewardship and Chief of the Infectious Disease Section at Henry Ford West Bloomfield Hospital. Board certified in both internal medicine and infectious disease, Dr. Stein plays a pivotal role on local and national committees dedicated to advancing infection prevention and antimicrobial stewardship, reflecting her commitment to excellence and innovation in patient care. Thank you guys all so much for being here with us today.
So let's start with the basics, ladies. What exactly is a nasal antiseptic, and how is it different from an antibiotic like, I always mispronounce mupirocin. It's mupirocin, right? All right. Mm-hmm. Good. All right. Got it. So how is it different from mupirocin, which hospitals have been using for years?
That is a great question and kind of loaded. So I'm going to apologize in advance for the long-winded question, but it is necessary, unfortunately. So when it comes to an antiseptic in general, It's a substance that's used to inhibit or kill disease-causing organisms that reside on living tissues, as we are all very familiar with. So when we look at a nasal antiseptic, then it's just how it sounds. It's an antiseptic that, when applied to both nares within the nose, it kills or inhibits disease-causing organisms within the nose. So this is particularly applicable when looking to prevent transmission of methicillin-resistant Staphylococcus aureus, otherwise known as MRSA. So MRSA usually colonizes the nares or the skin of an individual. So when it comes to nasal decolonization and it's targeting it at the source, it's killing or inhibiting it and preventing carriers from spreading MRSA to other individuals, both directly and indirectly. So to kind of answer why nasal antiseptic is different from mupirocin, I feel I need to explain, the current options that are available out there. There are currently 3 nasal decolonization options, and I'm going to touch a bit on each of these so we understand the commonalities and differences, as well as some of the positives and negatives associated with each of these options. So first, as mentioned, is mupirocin, which is a topical antibiotic that works by preventing bacterial protein synthesis and is known to be effective against MRSA. So it's considered widely effective since it's also effective against Staphylococcus species, most streptococci, and some gram-negative bacteria. So when we compare this to nasal antiseptic, true effectiveness against MRSA can take approximately 3 to 5 days with repeated application. And there's also concern of mupirocin resistance, as this is an antibiotic used preventatively. So for instance, studies have found that 22% of MRSA isolates were resistant to mupirocin as recent as 2023. So now looking at the second option, which is povidone iodine, which I know we didn't necessarily talk about in the beginning question, but I do think it is pertinent as it's kind of an intermediate between the one that we used and then looking at mupirocin. So it's not necessarily an antibiotic, but it's rather considered a bactericidal agent, and it is also an antiseptic. So it functions by killing organisms directly and is also effective against MRSA, including strains resistant to mupirocin, which sounds pretty great. While it's not linked to this antibiotic resistance, studies suggest that the nasal secretions reduce the effectiveness of povidone iodine by 80 to 90%. So if you look at it that way, it's not necessarily the best solution for decolonization. So then we move into alcohol, which is what we use. So alcohol nasal decolonization works by denaturing cell proteins and is shown to be effective against most gram-positive and gram-negative microorganisms. It's not an antibiotic per se, but there's no risk of development of resistance because it's not an antibiotic. So, just like povidone iodine, that makes it more beneficial than using an antibiotic that may relate to resistance later on. What makes it better than povidone iodine is it's not shown to be less effective with nasal secretions. It's very fast acting and it has a 12-hour persistence once applied. So when comparing the 3, that made it the best choice for us, and that's why we chose to go with the alcohol over mupirocin.
Okay, great. That answered my next question, which was how you decided to use the alcohol-based antiseptic. So I guess I'll let Nikki go. Nikki, next question, I guess.
Sure. Yeah, I'm kind of interested in the why. So, why does cleaning out a patient's nose twice a day make a difference for bloodstream infections like MRSA bacteremia?
Yeah, so I can take this question. So, I think we touched a little bit briefly on this in the beginning about using the alcohol-based nasal antiseptic with the 12-hour persistence. So it takes effect pretty quickly. So it's typically applied every 12 hours to be effective or beneficial. So, the reasoning behind this is cleaning the patient's nose twice a day. That process is called nasal decolonization. So basically it helps prevent bloodstream infections by killing the Staph aureus bacteria in the nose, which is a common colonization site. So since the bacteria can spread from the nose to other parts of the body and cause an infection, Reducing that bacterial load in the nose minimizes the risk of serious infections like MRSA bacteremia, particularly in vulnerable patients, such as those with catheters in the ICU setting or those undergoing surgery.
If this intervention worked as well as your data suggest, what would it take for hospitals everywhere to start doing this routinely? Is it mostly cost? Is it the culture of the facility? Or is it just convincing people it's worth the effort?
That is a great question. So like most new initiatives in healthcare, widespread implementation is multifaceted, often tied to cost, culture, and whether people genuinely see its value. So one core principle of improvement work that we live by in our hospital is to try to start small wherever possible. And then strong leadership support and buy-in from the clinicians who are actually ordering the product, like the physician order, and those administering the product, that buy-in is essential. So pilot testing the intervention on 1 or 2 units can be helpful, especially those that have higher MRSA bacteremia rates, for example. And this allows a hospital to work through those specific nuances prior to scaling this up to, say, multiple units. And once the process on the smaller scale is smooth and improved outcomes are demonstrated, broader adoption can become a lot easier. Of course, cost always is part of the equation. However, this product is relatively inexpensive if you compare it to the nearly $10,000 attributed to a single hospital onset MRSA bacteremia case. And that also doesn't account for the impact on our external reporting and reputation programs like CMS, IQR, value-based purchasing, and our hack reduction program. And then lastly, culture, of course, is key. We did really rely on our nursing leaders to help hold our frontline team members accountable and help us reinforce the why behind the intervention. As infection preventionists, we try to be on the units as much as we can, but there are competing priorities, and we partner with our nurse leaders who are consistently present on the unit. So their support is really going to be critical in sustaining the practice.
Great, thank you.
Okay. So let's talk about measurement. How did you actually track whether the patients received their twice daily applications? And how much do you think that compliance influenced your results?
Sure. So focusing on the tracking element, once the product was introduced to the ICU clinical staff in August of 2021, we educated on it. It was stocked by supply chain. We gave these units a bit of time to become adjusted to using the product and the documentation build within the electronic medical record, which I'm going to refer to the EMR moving forward just because it's a little more simplistic. With using the EMR prior to beginning our manual data tracking in December of 2021. So at that time, when we partnered with our EMR liaison to create the report within the EMR that depicted the last 7 administrations of our alcohol-based nasal antiseptic, along with the nasal antiseptic order within each patient in the ICU. So it gave us a general overview of the past few days of administration, so we could really hone in and track compliance that way with just utilizing this report within the EMR. This report was reviewed each weekday morning by our infection prevention team. And if an order was not placed or a dose was missed for a patient, the IP team would notify the ICU leadership to follow up and ensure that was ordered and the patient was given given the product if appropriate. We manually recorded compliance for each of our ICUs individually and would report these findings out monthly at our ICU meetings, which we thought to be imperative as feedback, provides that change that we're looking for. So if compliance was low, we would have an open discussion with our clinical staff as to what their barriers were and how we could assist. And so we continued this manual data tracking up until November of 2023. which is when our hospital system began to utilize analytic dashboards to tabulate the data electronically. And these dashboards were validated by our team, so they were comparative to how we were currently tracking the data. However, just based on a few definition changes, we could not include that data within the study, unfortunately. But we did see a similar trend that we will discuss a bit later with the data that we tracked manually. We do feel that compliance with the alcohol-based nasal antiseptic influenced our results quite a significant amount, since the only new component added to our MRSA prevention bundle during our study was, this product. Our findings showed a decrease in our SIR from 1.18 in 2021 to 0.9 in 2023, utilizing the same NHSN baseline of 2015. So, and I know I didn't mention 2022 in there, but there was still a decline from 2021 to 2022, and then from 2022 to 2023.
Thanks so much. And, we all know implementation is where the real test happens. We do PDSA cycles and other DMAIC and Six Sigma type processes to roll things out. But what challenges did you face as you were integrating this into the daily workflows? And how did you keep staff from feeling like, oh, we're being asked to do one more thing?
Yeah, so documenting administration of the nasal antiseptic was a challenge that we ran into early on, and I don't think it'll ever be fully resolved, but we have, of course, seen improvements. When documenting antiseptic use or the lack thereof in the EMR, nursing has the option to document yes, given, no, patient refused, and no, product not available. And when we initially started this study, we had heard anecdotally that sometimes the product was being given, but it's not documented. And as we know, if it's not documented, it's not
right.
done. That's the mindset that we have to live by in healthcare. So we worked closely with our ICU nurse leaders to help improve the documentation to ensure that our teams are getting credit for what they're doing. And we want the documentation to happen despite whether it's being given or not. We know there's some instances where it could maybe not be given, and that way we could learn what the barriers were. So through that, we did learn of situations where the product was contraindicated due to maybe the patient had some kind of like nasal surgery or something like that. So the health system that we are in made the decision to add the option of no, the product is contraindicated as a documentation option. So making sure that we have all of the potentials covered there. But documentation aside, it did also help that the nasal antiseptic was in the EMR as an order at all. So it's not necessarily, a medication. This isn't stocked in our medication rooms, but having it, as an order helped keeping it on the list and making it easy for our nursing teams to remember to provide it and to document it.
That's great. And I really appreciate the piece about making sure that all of the appropriate potential ways to document whether it was given or not given and why, because we actually see that in some cases, even with other things like our devices, and where nursing feels like they don't really have an appropriate way to document why it's there. And so I think making sure that we give them the appropriate tools to use will also help with complete documentation. One other question that I had is around patient satisfaction. So did you note any things from the patients around whether they whether this was a patient satisfier or dissatisfier? And I know in the ICU, you may not necessarily know, obviously, because patients are sleeping, but I don't know if you were able to determine this from any of your patient population at all.
Yeah, I don't have specific numbers on that, but as you said, in the ICU, a lot of the patients are asleep. So, and we'll talk about more later of how this has expanded over time. But now that we also do use the nasal antiseptic In our general practice units on patients with central lines, we do see a little bit more of the patient refusal. Some people don't want to stick something in their nose. Some people might hate citrus, and this product is alcohol and then a citrus emollient with it. But we really rely on the education done by our nursing teams. And sometimes it does have to get escalated up further to maybe a nurse manager or the provider coming in to really help explain the why behind it. And, it is an order in the chart. So we try to, tell our patients that, this is something that your provider has ordered for you. We want you to take this. And we do have some instances of refusal, but I think once we have those conversations with the patients, that it definitely helps. And sometimes the nurses will even, show how or discuss how they've used it on themselves, and that can also help with getting them to accept.
That's a nice way of doing it. And maybe someday it'll be like fluoride and we'll have different flavors, scents to choose from.
I know most people at the bedside would love to decolonize themselves of everything because we are all carrying something. Your MRSA cert, or for those listening, standardized infection ratio, it dropped from 1.18 to 0.90. But that wasn't statistically significant. So what's your take on that? And does the clinical impact still matter even when the p-value doesn't cooperate?
So I wouldn't necessarily say it was our SIRs that were statistically insignificant. As we were conducting the study, we did not really look at the statistical significance of the SIR, since with NHSN reporting, this already uses a regression model to compare our hospitals across like hospitals across the nation. So it's meant as more of an improvement metric. So when you're trying to tie an SIR to that, especially when it's not our regression model and we don't have access to what kind of went into that, it's going to be very difficult to assign a p-value to it. However, we did look at the p-values consistent with our MRSA rates by year, specifically to our hospital, which was statistically insignificant when comparing 2021 to 2022 and then 2022 to 2023. So our MRSA totals were already low to begin with. And when you look at p-values with a low number, the total number of observed events can have a major impact on that p-value. And since our MRSA totals each year were in the single digits, it makes it very difficult for us to find any statistical significance when comparing one year to the next. So it's an example of why I don't always like to rely on that p-value when considering an intervention success. And it's one of those things that kind of rubs me the wrong way as a data analyst when everyone's just like, oh, the p-value is insignificant. That doesn't really mean anything. I wouldn't necessarily say that when it comes to studies. So because our SIRs went from above 1 to 2021 to below 1 in 2023, and our percentage of patients in both the ICUs saw a statistically significant increase in compliance from 2021 up through 2023, I believe we can say there's a positive correlation between that compliance and that decreased SIR from that time range of 2021 to 2023. And therefore, there was a clinical impact, even though that p-value may not necessarily be the most significant.
And I think what you said there is what resonates with me is it's the clinical impact. Like every patient matters. And so when we see even small reductions in small numbers, I think that in my mind, that is actually making a difference.
Yes, absolutely.
So you also followed the Squire 2.0 guidelines when reporting this work. And for those not steeped in the QI frameworks, what do these guidelines add to a project like this?
So Squire, which stands for the Standards for Quality Improvement Reporting Excellence, I'll say that 5 times fast. They're international standards that help people like us share quality improvement work in a clear and scientific way. So we used the Squire guidelines to shape our story. We wanted to ensure it was ready for publication. So Squire allows us to just answer some very simple questions. Makes sure that we explain what we did, why we did it, and what we learned in a format that the intended audience easily could follow. So quality improvement projects really use a wide range of methods to connect actions and outcomes, and Squire just helped us provide that roadmap for describing work at the level that's expected in a scientific publication. So simply put, Squire helped us bring clarity and rigor to our story.
I love that. I think that's fantastic. So stepping back a bit, what barriers might other hospitals run into if they tried this, thinking about the implementation and the culture and those types of things that we sort of talked about earlier? Thinking about even long-term care, acute care, where twice daily anything could be hard to sustain, but also financially and realistically, and all of those reasons sort of that we talked about in the beginning, but like what barriers might other facilities be up against?
Yeah, this is a really important question. And, I anticipate that many hospitals would run into some similar challenges that we ran into. When we started the initiative, our infection preventionists were pulling reports from the electronic medical record every day and keeping a spreadsheet of who received the nasal antiseptic. Eventually, they were able to assist in building an electronic dashboard, which made the process far more sustainable. And every facility may not have that same level of IT support. So, for those hospitals, long-term tracking may not be the most sustainable, right, in the long term. So that's one of the things to consider. And in our paper, we actually made mention of, several barriers that we encountered. Hopefully to help other groups that were looking to potentially implement a similar process. So that way they could, anticipate these barriers and kind of troubleshoot ahead of time. But some of the challenges we had were with automated reporting, inconsistent administration, production location and documentation. So these are all things to kind of keep in mind when you are looking to implement a process like this. And definitely getting buy-in, right, from your frontline staff and your leadership teams, I think is really important to kind of help these go smoother.
Right.
With the long-term acute care setting piece you asked about, I'm sure there's going to be some concern with the burden of the twice daily application. There's always a concern for cost. But in these settings, it's worth remembering we're doing many of these tasks multiple times a day, right? Patients are getting vital sign assessments, they're getting medication administrations, wound care, just to name a few. And these are already occurring multiple times a day. So bundling interventions and working them into the daily kind of workflows, I think, is key. And as Alex had mentioned earlier, right, cost is always a concern in healthcare, but the product cost is far lower than the cost of an infection, especially for those vulnerable patients. So, while there are real barriers, they're not insurmountable. And with thoughtful workflow integration and early troubleshooting, it is really feasible to implement and sustain these in other settings.
Yeah, you make a great point about the cost avoidance. I think that sometimes is a hard case for us to make, right? Because they're looking at that money that's being spent up front, and it's kind of like the what if this happens, right? But I do think it makes a lot of sense to talk about the cost of the infections, especially as you mentioned earlier, the hack reporting and all of that is we don't always necessarily include in that conversation, but also becomes a cost to the facility. Do you think that something like this could work outside of the ICU, or do you think it makes the most sense in those high acuity settings? I know you mentioned you did have some transition to other locations.
Yes. So we have been expanding this outside of our ICUs. So for the past couple of years, we've been using the twice daily nasal antiseptic for our non-ICU patients that have central lines. And honestly, using this product outside of the ICU does make a lot of sense. We had been using our chlorhexidine bathing as well in all of our ICU patients and on our GPU patients, the central lines. And now we're kind of adding that nasal antiseptic along with that. But since the pandemic, we have really seen a shift in inpatient acuity. So a lot of patients who were cared for in the traditional med-surg setting are sometimes now being managed in alternative models like acute care at home. And that means the patients that are physically in the hospital are much sicker than before. So we have our ICU patients, but even the patients on the GPUs are, sicker than they used to be. Because of that shift, it's important to really consider interventions across all inpatient units, not just the ICUs. And our experience is showing that with our clear and supported workflows, nasal decolonization programs can be successfully implemented. And while the ICU might be the most intuitive place to start, it doesn't mean that it has to end there.
Absolutely. And one of the things that I love about this study is how it reflects a shift in mindset away from antibiotics as the only answer toward strategies that prevent infection without fueling resistance. It's practical, scalable, and frankly, it's overdue.
And I would completely agree with you. Ever since the discovery of antibiotics, we as a collective, and when I say collective, I mean not necessarily just hospital personnel, but us as a society, have been reliant on them as the ultimate cure for most ailments. And so because of this mindset, we have seen a substantial increase in our antibiotic-resistant organisms. And what's truly terrifying is we have these emerging organisms such as vancomycin-resistant Staph aureus or VRSA that are resistant to all forms of antibiotics currently known to treat it. So science is beginning to turn its attention to other forms of treatment rather than antibiotics, which is truly exciting, and something like a nasal antiseptic that we are now starting to think about. It's like more of a proactive response rather than a reactive response like an antibiotic use.
Yeah, absolutely. And another thing that stands out to me is how success came down to both the science and the systems. The product mattered, but so did supply access, communication, engagement. It was a cultural win as much as it was a clinical win.
Yeah, absolutely. I mean, we can't just stock a new product on the shelf in a supply room and expect that everything will be used as intended. So we have to tap into multiple resources. Nursing education, our own infection prevention education, nurse leaders, supply chain, information technology, in addition to what we do on the floors daily to be successful with an intervention like this.
It's so funny that you mentioned, you can't just throw something on the shelf and expect people to use it, because that I have observed on more than one occasion where staff doesn't even know that product exists or where it is or how to, that is wild. But infection prevention definitely works best when it becomes part of that daily rhythm. It's not a special project. It's just, as you mentioned, it becomes part of that daily workflow, part of that bundle of things that we're doing. So this is such a great example of that.
And I love how you mentioned infection prevention works best when it's part of a daily rhythm, because as Alex mentioned in one of her points earlier, it really comes down to the culture that you have within your hospital, right? So accepting and integrating infection control as part of a daily rhythm obviously doesn't happen overnight. It's going to take a lot of work from the infection prevention team with the support of hospital leadership to ensure a face is put to the name. And the information that we provide is also trustworthy, and why interventions we introduce are important and will lead to better patient outcomes.
Exactly. Well, thank you all so much for joining us today and walking us through the process as well as your successes, and also, talking about some of the potential barriers, but how we might overcome those.
Absolutely. And thanks for having us. We really appreciate you reaching out and giving us the opportunity to share what a little hospital in Michigan is doing to try to prevent our MRSA rates from increasing.
Well, I always say sharing is caring, and we all have a lot to learn from each other. So we really need to spread our knowledge so that we can all be doing our best for our patients. And to our listeners, if you're looking at the noses in your ICU a little differently, consider that a professional side effect. We'll be back next time with more science, more stories, and a few ideas worth borrowing. Until then, keep it clean, everyone.
And that's a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.